Pleasure to be here. So I'm just going to share my screen. And we'll just go up to the top. Sorry, should have done that to begin with. I might exit for a second. I'll just go to the top. Okay. So today, so my name, as Annalise mentioned, is Justine Millar. I work in the Shire called Shire Family ENT. Today I'm going to be talking about some common ENT disorders. And I really wanted to go through 5 different cases to kind of discuss the common things that we see. I want to discuss a young child that presents with a sore ear, a child that has difficulty sleeping, a child with noisy breathing, an adult with dysphonia, and an adult with nasal symptoms. So the first case is a mum that brings her 2-year-old boy in with ear pain. So from the history, what I want to know is if the pain is arising from the ear or whether or not it's referred to the ear. Whenever I'm taking history, I always go back to first principles and the sort of basic history taking. Start off with Socrates, so site, onset, character of the pain, radiation of the pain, associations, time course, exacerbating and relieving factors, and severity. Any ear concerns, I always want to know whether the child has a fever, whether there is discharge, whether there's any hearing loss. No, not so much for children, but more so for adults. I also want to know about tinnitus. I want to know about vertigo and whether the child's off balance. I want to know whether or not they complain of blocked ears or sort of fullness in the ear. Facial movement, so if they've noticed any unusual facial movement, they have a past history of ear disease, or they've had any trauma to the ear. In terms of background, I generally want to know whether they're a full-term baby or preemie, their development, vaccination status, newborn hearing test, whether or not they passed it, family history of ear disease, daycare attendance and swimming lessons, dummy or bottle use, allergies, parental smoking, reflux and teething. And then I move on to my examination. So when I examine the patient, start right from the very basic stuff, so you can examine the external ear to start off with. If I see a picture like this, so you can see in this picture the patient's ear is protruding and sitting forward, and there is erythema behind the ear. It's mastoiditis with or without subperiosteal abscess until proven otherwise. And if I see a child like that, the patient should be sent straight up to ED with a letter for ENT review and intravenous antibiotics. Looking at the front of the ear, if you see a picture like this with some swelling around a preauricular pit, this is an infected preauricular sinus. The patient should be started on some antibiotics for 48 hours orally, and then a swab if you can, any pus that may be coming out of the punctum, and review the child again in 48 hours. If they're no better, send them to emergency for intravenous antibiotics because they may need incision and drainage of that area. We try not to incise unless we absolutely have to, because it makes it more difficult when we do actually excise the whole cyst. If the child's symptoms improve though with the antibiotics and they don't get worse, then you need to continue the oral antibiotics for 10 days and provided that it's getting better, send them for ENT review. Looking at the pinna, if it looks like they've got a history of trauma and it looks like this, then it's a pinna hematoma, and that should be sent up to emergency with a letter for ENT review. It will need incision and drainage because of the blood supply to the cartilage of the ear. It should be addressed immediately so that we can try and save the cosmesis of the pinna. If you see a picture like this, this is a cellulitis of the ear, and you can see here that there is involvement of the lobule of the ear. If a child has or an adult has a perichondritis, it doesn't involve this bottom part. So this is a patient with cellulitis. So pinna cellulitis, you start off with oral antibiotics. If the ear canal looks okay, it's always incredibly painful. So make sure that you give them some analgesia. And if there's no improvement after 48 hours, they may require intravenous antibiotics in hospital, so send them up to emergency. Then once you've looked at the external part of the ear, then look at the ear on the inside, and you can see in this picture, often you're confronted with a picture that looks a bit like this. This is earwax, and often when you look in the ear, that's all you can see, and it completely obstructs your view of the eardrum. If you try and change, and I always remember someone telling me that, you need to look past the wax, and I thought that was always the most ridiculous thing to be told. But if you actually change the angle of your otoscope, you sometimes, and often you can actually see into the distance and see the tympanic membrane past that wax. If you can't, put them on some olive oil and either send them up to see me or bring them back. If you see a picture like this, this is Keratosis obturans of the ear canal. Keratosis obturans is basically a buildup of the keratin within the external auditory canal. It can start to cause erosion of the ear canal if left alone. So if you see a picture like that, please send them to an ENT surgeon. And if acutely infected, start them on some oral antibiotics and ear drops. If you see a picture like this, this is a picture of dermatitis of the ear canal. The treatment for this is Elecon ointment and olive oil. Ask the patient to keep their ears dry, and more than happy to see any patient with dermatitis of the ear canal, because often they'll need micro ear toilet. And I will see often patients every 3 months or so to do a micro ear toilet for them, because they often get buildup of wax associated with the dermatitis. It's really important that you make sure that they keep their ears dry, because if they get water in the ears, they'll end up with an Otatus Externa. If you see a picture like this, this is a furuncle of the ear canal, and you can see here there's a little area there where there's some pus there. The furuncle of the ear canal needs to be treated with oral antibiotics. Consider, if it doesn't settle down, an incision and drainage, and sending them to an ENT surgeon for treatment. If you see a picture that looks a bit more like this, this is an Otatus Externa. What I want to do, if you see that, is to take a swab with one of the orange swabs, and you can get the orange swabs from Lavity or any of the pathology places. They're a little bit thinner and much easier to get into the ear canal. The blue ones tend not to really get to where you want it to go, so just be a bit careful with those blue ones. Encourage the patient to keep the ear dry. Treat them with Sofradex until sensitivities are back, and then if it looks like there's a Pseudomonas infection, change them over to a Cipra HC or Siloxane ear drops. If it doesn't settle down, then send them to an ENT surgeon for micro ear suction. If you see a picture like this, that's fungal Otatus Externa. Take an ear swab with orange swab for the MCS, keep the ear dry, start them on some Locacortin Viaform or Oticome Otic ear drops until the swab result is back, and send them to an ENT surgeon if it doesn't settle down for micro ear suction. If you see a patient that looks a bit like this could potentially be a traumatic perforation. Make sure you keep the ear dry, Siloxane ear drops to clear the blood, send for a hearing test and ENT review. If you see this is a red mass behind the ear. This is a globus tympanicum. So if you see a red mass behind the ear, please send the patient for a hearing test and ENT review, and a CT picture temporal bone, depending on the age of the child. Okay, so this is what we most commonly will see. This is an acute otitis media. Generally, look, the antibiotic guidelines are constantly changing, but at the moment, we observe the child for 24 hours and recheck unless they are less than 6 months old and it's unilateral, less than 2 years old with bilateral infection. If they are systemically unwell, so they're lethargic, pale, irritable, if they've got an Aboriginal Torres Strait Islander background, if they're at risk of complications or immunocompromised. Amoxicillin if not responding after 48 hours, and so if after 24 hours you give them amoxicillin, if they're not responding after 48 hours, give them augmentin. If they've got a perforation, then also put them on Siloxane ear drops as well as the oral antibiotics, and keep the ear dry. Always check the patient's facial nerve, and if the child has had more than 4 infections in 6 months, then send them for ENT review. If you have a look here and you see a picture like this is otitis media with effusion. What I generally would say is that if the patient has had a recent upper respiratory tract infection, bring them back in a couple of weeks to recheck, because often kids with an upper respiratory tract infection will have some fluid within the ears. If the fluid is still there after you review them, then send them for a hearing test. Ask the parents about speech and language development, consider an otovent, and giving them intranasal steroids. Now, there's really no evidence to support intranasal steroids to reduce OME, but it's often given. So when do I send a patient for ENT review? Well, basically, if the glue has been present for more than 3 months with no speech and language delay, worry about long-term damage to the tympanic membrane and hearing apparatus. And I would recommend that they be sent on. If the pure tone audiogram shows 40 decibels of hearing loss or greater, if the pure tone audiogram shows less than 40 decibels of hearing loss, but the parents report speech and language delay, if the child is having balance problems causing delay in walking, or if the child has an underlying hearing loss as well as the glue ear. If my examination is unremarkable, then it'd be thinking, well, could it be referred pain from the tonsillitis, teething, or lymphadenitis? So always go back and examine the oral cavity as well as the neck. Moving on to case 2. So your patient brings in her 4-year-old child who has not been sleeping well. So differential diagnosis for this includes obstructive sleep apnea, reflux constipation, allergic rhinitis, iron deficiency, and sleep disorder. From the history, I want to know if the child snores. Does she have difficulty going off to sleep, or does she wake throughout the night? Is she restless? Is she sweaty? Does she have apneas or pauses in breathing? Any enuresis, open mouth breathing and neck extension, teeth grinding, difficulty concentrating, irritability or hyperactivity during the day? From a background history point of view, I want to know the onset. How long has she had the symptoms? Was she a full-term baby? Did she spend time in NICU? Does she have a history of reflux? Does the child drink a lot of milk or have iron deficiency? Do they have a history of allergic rhinitis or a history of recurrent tonsillitis? So in terms of what we do, so for if you think the child has obstructive sleep apnea, you'd be thinking about a sleep study or ENT review. Reflux constipation, omeprazole, osmolax, and gastroenterologist, allergic rhinitis, immunologist, intranasal steroids and bloods, and iron deficiency bloods, iron replacement and recheck in 3 months. If you think they've got a sleep disorder, melatonin and sleep physician review. On examination, I look at the general appearance of the child. Is the child failing to thrive? What is their weight? Are they obese? Does the child destroy my office and everything in sight and is super hyperactive at the time of the consultation? Do they sit in the consultation with their mouth open? On examination, then I move on to the eyes and the nose for allergic rhinitis and looking for allergic shyness. Could also be from lack of sleep, but often it's related to allergic rhinitis. Denny-Morgan lines, which are the lines under the skin folds under the eyes that become inflamed from allergic rhinitis, allergic eyelashes, supra-tip crease and allergic salute. So is the child constantly doing this during the consultation? And then in terms of anterior rhinoscopy, essentially if you can hold the child still and get the parent to hold the child still enough, look up the nose with an otoscope. And if you see a picture that looks like this with a really inflamed, boggy, swollen inferior turbinate, it's likely to be allergic rhinitis. And if you're not quite sure, in terms of the turbinate, a normal turbinate, you should have a decent distance between the septum and the turbinate, whereas you can see in that picture there is very little space there. It's touching the septum, which is classic for allergic rhinitis. Allergic mucin often looks like a rubber band. So if you see really sticky mucus coming out of the nose that's really like a rubber band, it's likely to be allergic type mucin. So with allergic rhinitis, the key is identifying the allergen with either blood test or skin prick testing. I often send the patients for IgE and RAS testing. For RAS testing, I usually just do common allergies like house dust mites, molds, and often like an Australian pollen mix. And if the patient has an animal, often do an animal epithelial mix. education on avoidance to reduce exposure of the allergen, intranasal steroid, and often the parents will come back and say the bottle said you can't use it under 12. So look, there's good evidence to say that there is very little systemic absorption with a lot of the intranasal steroids that are used and are unlikely to cause any long-term effects. They can cause some thinning of the lining of the nose, and they can cause some epistaxis. So if that's occurring, then they may need to be ceased. But you can reassure the patients that they are really safe to use. Intranasal antihistamines or oral antihistamines, I often combine the intranasal steroid with an nasal antihistamine called dimistonasal spray, which just means that they can use one spray each nostril at night before they go to bed, rather than having multiple bottles. And referral to an immunologist and ENT surgeon. If you look up the nose and you see a picture a little bit more like this with your otoscope, then you'd be worried that that represents a nasal polyp, which is really uncommon in children. If you see nasal polyps in a child, you really need to suspect cystic fibrosis or primary ancillary dyskinesia. And so in that case, they need to be seen by a respiratory team and be tested for this. Also refer them for ENT and start them on some intranasal steroids and wash. On general appearance, if you see a picture like this is classic for a child that has adenoid facies, which is a long, thin face with mid-face hypoplasia, crowded teeth, high arch palate, they have an overbite, narrow maxillary arch, and open mouth posture. If you see a picture like that, send them to an ENT for either nasal endoscopy or a lateral airways x-ray before they go and see them. Now, in terms of the lateral airways x-ray, it's really important to make sure when you're looking at the x-ray that the area that we're looking at is actually this area here. So I'm looking at the obstruction of the choana with the adenoid tissue. So I'm not so much interested in this part here, but more this part here in that area. So you can see in this x-ray, it's completely obstructed by adenoid tissue. This is a nasendoscopic view of the adenoid tissue. Then I move on to my oral examination. So first I look at the palate. So in this picture, you can see a really high arch palate. So high arch palate can be associated with open mouth breathing posture and nasal obstruction. If you see that, it's probably a good idea to send them to an ENT surgeon for airway assessment and to the dentist for further assessment. When you look at the back of the throat, if you see a picture like that, that is kissing tonsils. So that's grade 4 tonsils. If you have symptoms of sleep disorder breathing and those tonsils, it's very likely that that's the issue and they're likely to need tonsillectomy. In terms of tonsil grading, essentially the picture that I've just shown you isn't quite right because grade 4 is actually touching the midline, whereas on the picture there's still a gap there. But grade 0 is previous tonsillectomy, grade 1 the tonsils aren't obviously visible, grade 2 is within the pillars, 3 beyond the tonsillar pillars, and 4 is touching the midline. So grade 3 can be really variable. Sometimes it's just past the pillar and sometimes it's almost touching. So there's a huge variation in grade 3. With a child with OSA, often the parents will come in and show a picture of their child with that open mouth posture or a video of them snoring and obstructing. If the oral examination shows big tonsils and they have a history consistent with OSA, send them to an ENT surgeon. If the parents are unsure about OSA, then send them to a sleep physician first. If you look at the throat and it looks a little bit like this, this is a picture of acute bacterial tonsillitis. So essentially, treat them for 10 days with oral antibiotics. Penicillin is the first choice. Penicillin V. If they're allergic penicillin, you can put them on Keflex. If they have a very strong allergy, they can put on azithromycin, which only needs to be given for 5 days, whereas penicillin and Keflex will need to be given for 10 days. Also looking out for pictures like this, which is not seen very often. If you see spots on the palate like this and a rash on the face and a strawberry tongue, think scarlet fever. The treatment is as per acute tonsillitis. Watch out for complications, so check for cardiac and renal problems. And the treatment is exactly the same as you would for acute tonsillitis. If you see a picture like this, this is a picture of an asymmetrical pillar. So that's a quinsy. So if you see a quinsy, send them up to ED for incision and drainage. They'll need intravenous antibiotics, and often they'll need sort of 24 hours in hospital. The patient has a 20% chance of the quinsy recurring. So once the treatment's complete, consider ENT referral. If you see a picture like this, this is a horrendous picture, but this real pseudo-membranous slough on the tonsils. This is classic for EBV tonsillitis. And the treatment for this is steroids and I often put the patients on antibiotics as well to treat a superinfection of the slough. Just be careful not to put them on amoxicillin, because they often will get a rash associated with it. So I often put them just on plain penicillin. Ask about other symptoms, liver, spleen, fatigue. Send them for bloods, and it's really important to make sure you do an LFT to check for the liver function, as well as you can send them for EBV-C and V serology. If there's no improvement with the oral steroids, it's really, and often these patients will need an admission to hospital, at least for 24 hours, often for intravenous hydration and IV steroids. So send them up to ED if that's the case. It can take 6 weeks before they feel back to normal. So it's really common after their admission to hospital that they will come back multiple times saying they feel horrendous. Eventually, all of a sudden, they'll feel better. If you see a picture like this with these little stones in the tonsils, these are tonsil stones. They're really quite uncommon in children, but can be present in children. They're due to the bacteria living within the tonsillar crypts. They can cause quite bad halitosis, and if the halitosis is significantly impacting the patient from a social perspective, then an ENT referral is appropriate. There's really no evidence to support any of the treatments except for tonsillectomy. So if it's bothering them, they need their tonsils out. So in terms of sleeping difficulty in a child, this question comes up all the time, and it's a really tricky one. Basically, when do you send the patient to an ENT surgeon, and when do you send the patient to a sleep physician? And in my hands, and maybe the sleep physicians would disagree with this, but basically if the child has most of the symptoms of sleep disordered breathing and either large tonsils, large adenoids and/or large turbinates, then send them to ENT. If the child doesn't quite have all the symptoms of OSA, or the parents are anxious and unsure whether or not they've got it, or they have the symptoms of OSA, but they have tonsils, adenoids and turbinates that don't look particularly big, then send them for a sleep study first. All right, I'm going to move on to case 3 now. So a mum brings in her 6-week-old baby with noisy breathing. So from the history, I want to know if the noise is on inspiration, which means the pathology is above the vocal cords, whether it's biphasic, which implies that the pathology is at the level of the vocal cords, or whether or not it's on expiration, which is below the level of the vocal cords. And often this can be quite difficult. And so if the parents can either take a video or you can watch them in your rooms, it might be easier to try and ascertain whether or not that's occurring. Basically, in terms of inspiration, we think of laryngomalacia, stertor from the upper airways, or a vallecular cyst, some of the examples. Biphasic, it could be a foreign body lodged in the vocal cords, laryngeal papillomatosis, laryngeal cyst, bilateral vocal cord palsies, or a laryngeal web. On expiration, it could be tracheomalacia, vascular ring, foreign body, croup, and respiratory pathology. So from the history, I want to know the timing. How long has the noise been there? Has it been there since birth, 1 day, 1 week? Whether it's a gradual or sudden onset, other symptoms of distress, weight gain or failure to thrive? Is the cry normal? Any witness cyanosis, or worse on feeding and crying? When to send to ED. So if it is a sudden onset, I want to exclude a foreign body. Symptoms of airway distress or cyanosis. So you can see here this child had a vallecular cyst, but they've got significant airway distress. I don't know if you can see that from these pictures very well, but significant subcostal recession in this. So in terms of when, you'll see lots of patients, obviously you see lots of patients with croup, and I think in terms of when to treat a child with noisy breathing with croup, it's really a matter of how distressed the child is and their history and how confident you feel that it is croup. When to send to an ENT for all other inspiratory or biphasic noise, and when to send to a respiratory paediatrician for all expiratory noise or wheeze. Just wanted to go through a few things that you don't want to miss. This is a foreign body wedged in between the vocal cords. So this is a child that had biphasic stridor. This is a foreign body wedged in the left main bronchus here. This is a foreign body in the left main bronchus causing hyperinflation of the lungs. You can see there's flattening of the diaphragm, and there's actually collapse as a result of the right lung. A button battery wedged in the upper esophagus. So often kids with a button battery will drool, have issues with swallowing, but they can also get some noisy breathing associated with the edema that they get. And a retropharyngeal abscess. Again, the child will be drooling, not moving their neck, but again, can have some noisy breathing. Okay, we're going to move on from paediatrics now and go to a couple of adult cases. So the first case I wanted to discuss is a middle-aged man that presents with dysphonia. So from the history, I want to know the timing. How long has the hoarse voice been there? Years, months or days? The onset, whether it's gradual or sudden? Is it constant or intermittent? Are there any associated throat pain or radiation, particularly if the patient is complaining of ear pain? Hemoptysis or hematemesis, weight loss or anorexia, dysphagia or odonophagia. In terms of background, I want to know if the patient is a smoker, consumes alcohol. I want to understand what they do for their work, for example, if they're a teacher or not, what sort of family support they have, what sort of social history they have, previous head and neck radiation, other malignancies, other medical problems, for example, reflux or postnasal drip. In terms of differential diagnosis, it's huge. These are some of them. Malignancy, vocal cord nodules, vocal cord polyp, vocal cord papillomatosis, vocal cord palsies or paresis, functional voice disorders such as muscle tension dysphonia, spasmodic dysphonia, reflux, postnasal drip, edema, Reinke's edema, laryngitis, presbyphonia or glottic gap, post-traumatic arytenoidislocation or laryngeal web. So in all cases of dysphonia, think malignancy until proven otherwise, and always check the neck for lymphadenopathy. All dysphonia should be referred to an ENT surgeon urgently. Red flags for malignancy, so gradual onset over weeks to months, constant dysphonia, ear pain, pain that wakes them at night, dysphagia or odonophagia, anorexia and weight loss, hemoptysis or hematemesis, background of being a smoker, alcohol consumption or previous head and neck radiation. So just wanted to go through a few cases. So nodules are often seen in teachers and singers. They're often managed conservatively with voice amplification, voice hygiene, voice therapy and anti-reflux medication. Referral to an ENT surgeon or speech therapist to try and help them. And you can see this is a nasendoscopic view here of the nodules in the mid-vocal cord there. So they can be quite subtle. Polyps, so patients that often will describe an event, for example, they went to a football match or a party where they were shouting or using their voice a lot and then woke up the next day with a husky voice. The treatment for a vocal cord polyp is surgical, so they should be referred on for ENT review. Granulomas, often patients will either report a history of reflux trauma. The treatment for it is conservative. There is some evidence to suggest that conservative management can help. So often we'll give them up to 3 months to see whether or not just some anti-reflux medication will settle things down. If not, then they require surgical excision. They do have a tendency to recur, particularly if the patient has a chronic cough or any issues where they might be traumatizing the vocal cord. Reinke's edema is often seen in patients, and you can see these vocal cords are really swollen, that smoke or have reflux. They're treated, managed conservatively with smoking cessation, anti-reflux medication. We very occasionally go in there and operate on them, but try not to if at all possible. Papillomatosis, essentially surgical debridement is the treatment, laser, microdebrider or cold steel. Medical management is controversial. There's a whole lot of stuff out there, including interferon alpha, indole 3-carbinol, cidofovir, retinoic acid, cimetidine, all with variable success. Functional voice disorders, and these are really, really common, and most voice disorders that I see are functional. Muscle tension dysphonia is really common. It's due to sustained glottic supraglottic contraction, which is not task dependent. The treatment for it is speech therapy. Adductor spasmodic dysphonia or dystonia is incomplete vocal cord closure. Often the patients will present with a really breathy voice and absent voice, and they have no improvement with speech therapy. Adductor spasmodic dystonia is basically excessive vocal cord closure, so they get a really strained and strangled and stoppages in their voice. The treatment for them is EMG guided Botox, which is done at St. Vincent's. Vocal cord palsy, again, is much more common with patients with chest pathology on the left-hand side particularly. So important to ask about radiotherapy, malignancy or surgery. The treatment is medialization, either by injection or thyroplasty or reanimation. All right, so that's essentially to take away from the takeaway from any dysphonia is essentially they need to be reviewed and think malignancy until proven otherwise. The last case is a middle-aged woman that presents with facial pain and pressure and nasal obstruction. So based on the history, I want to know whether or not this is a functional or a structural issue of the nose, or is it something unrelated to the nose, for example, a headache syndrome. From the history, I want to know whether or not they have nasal obstruction, they have facial pain or pressure, they have any anosmia or hyposmia, they have any anterior rhinorrhea or postnasal drip, the pain worse on bending forward, time course, whether it's constant or intermittent, whether they have a history of atopy, itchy eyes or nose, a history of headaches and epistaxis. Differential diagnosis, essentially there's lots of different things it could be. I'll sort of split it up into 6 different things. I think that thinking either allergic rhinitis, a septal deviation and turbinate hypertrophy, chronic rhinosinusitis with or without polyps, acute rhinosinusitis, nasal malignancy or mid-facial segment pain. When I examine the patient, again, just like with any examination, you look at the whole patient, looking for conjunctivitis, allergic shyness, Denny-Morgan lines, allergic lashes, allergic salutes, supratip crease, turbinate hypertrophy. With allergic rhinitis, we did sort of go into this for the child as well, but identify era allergens, skin prick testing, IgE, RAST, reduce exposure, intranasal steroids or oral antihistamine, singular atrovent immunotherapy, surgery for turbinoplasty if nasal obstruction is the main complaint. Now, future directives, there is a lot of, and at the moment, Xolair is sort of medication that's being used for severe asthma. I'm sure that in the future that will potentially be used for allergic rhinitis and hopefully not in the too distant future. Septal deviation or turbinate hypertrophy, you can trial them on some intranasal steroids, refer them to an ENT for surgery if impacting the quality of life. And so in terms of the nasal examination, sorry, I should have swapped those 2 slides around. Always look at the external appearance of the nose, look for scars, obvious external deformity, tip support. Cottle's maneuver. Now, Cottle's maneuver is a terrible maneuver because basically all patients feel better when they have their nose lifted, but essentially what you're doing is you're sort of blocking one nostril and pulling up the other one to see if they get better airflow, which all patients will say it makes a significant improvement. But anyway, that's something to look at for valve collapse. Inferior view, so you look at the bottom of the nose, look at the columella and for caudal dislocation of the septum. Then look inside the nose with an otoscope to assess for polyps, turbinate hypertrophy, septal perforation, lesions on the septum. Now, if you see polyps or they've got a history that sounds very much like chronic rhinosinusitis, which is greater than 12 weeks of symptoms, start them on some flow sinus rinse and intranasal steroid wash. So I put patients on Pulmicort respules. The Pulmicort respules the way it works is basically they make their bottle of Sinus Rinse up as normal with the sachet of salt and the kettle boiled water that's been cooled, and then add the Pulmicort Referral, which is 1 milligram in 2 mils, to that bottle. And they flush half a bottle up one nostril and half a bottle up the other. Essentially, if they're using intranasal spray, none of that is getting into the sinuses, whereas there have been studies to show that approximately 30% of the intranasal wash will get into the sinus. The Pulmicort is thought to work directly through the eosinophils. It works indirectly through on the cytokines, and there's very little systemic absorption and side effects. So it's better in terms of tolerance by patients than oral steroids. Low-dose antibiotic use for chronic rhinosinusitis is really controversial. Most of the evidence is in patients without polyps, which is thought to be neutrophil driven, and patients can be placed on a 6-week course of a macrolide with variable success. Doxycycline can be effective for patients where you think that Staph aureus is driving it, and so a trial of doxycycline, provided that they understand the risks associated with it, can also be helpful. It's really important when you get them to sort of wash their nose out that they understand how to do it. And you can see this awful picture, but basically they need to flush half a bottle up one nostril and let it come out the other side. So it's the wash on the other side that actually it goes into the sinus. It's not the side that they're flushing up. Send them for a CT scan of their sinuses to assess for chronic rhinosinusitis, start them on a steroid nasal wash, and send them for ENT referral. In terms of surgery, the key decision is if it will help with burden of disease, surface area for the disease to affect, and increased room for topical treatment. Essentially, surgery is the last resort because being diagnosed with chronic rhinosinusitis is similar to being diagnosed with asthma. It's a chronic disease. It often starts off as a virus that causes some sort of inflammatory response within the nose, and then it becomes a cycle of inflammation. It's really important that we don't rush into surgery because if you've got polyps, the chances that they grow back is really high, and patients will still get postnasal drip and ongoing inflammation in their nose to some extent after surgery. So if I think that a patient is not getting adequate disease control with the topical treatment without surgery, that's when we'll intervene. But I always give them a trial of 6 weeks with medical management before we consider surgery. Okay, so acute rhinosinusitis is managed quite differently, and the symptoms are quite different as well. Patients will describe fever, facial pain and pressure, rhinorrhea, and it's often thick and green and disgusting, anosmia, or like a really bad smell in their nose. And you need to watch out or ask for complications such as periorbital cellulitis or meningitis. Treatment for ARS, I treat it with decongestant. It's really important with the decongestant just to put them on the decongestant for 3 to 5 days maximum. You can give topical steroids, so they can use the little Pulmicort Referals and sort of drop them in the nose, and antibiotics. So just follow the antibiotic guidelines, which again change constantly, but amoxicillin, if allergic, you can try or ceftriaxone or doxycycline. If they don't improve, then after 5 days, they need to be changed to Augmentin. If they've got a complication, send them straight to emergency for treatment. Sometimes patients with acute rhinosinusitis will need to be sent to emergency anyway because the pain and pressure is so severe that they're not coping with the oral antibiotics. In terms of headaches, this is one of the most frustrating things for patients because a lot of patients sort of get told their whole life that they have sinus disease when they actually may have some sort of headache syndrome, because often patients with mid-facial segment pain, which is pain across the sinuses, they'll often have a lot of similar symptoms to chronic rhinosinusitis. They may describe nasal obstruction, rhinorrhea, the facial pain and pressure. And so really the key is that their CT scan is clear. And if their CT scan is clear, despite their symptoms, they really need to be sent to a neurologist for medical management of their pain, because any sort of nasal treatment is, if anything, going to exacerbate their symptoms rather than improve them. Okay, any questions?
Justine, we've just got one really interesting question that's come through. It's from one of the physiotherapists listening in. It's, have you found any correlation between vitamin D deficiency and or hypocalcemia with recurrent benign positional vertigo?
Okay. Look, I don't know the answer to that. I'm sure it's possible. Vitamin D deficiency is obviously really common in the community. But I haven't specifically come across any studies that have looked at that, but I haven't looked at a study, so I'm not sure what the answer to that is. But if they've found a study that shows a correlation, it's probably worth replacing the vitamin D, but I don't normally start off with that as my first line of treatment for BPPV. Is the physio a vestibular physio?
I'm not entirely sure. Maybe if he's still online, you could post another question for us. Hang on, I'll just have a quick look at I can have a look at the attendees at the same time.
But yes, so classically for BPPV, it's all about trying to work out what stimulates it, and so often if it's, because it depends on which canal it's affecting, but essentially often patients will describe rolling over in bed, for example, to the left side and becoming acutely vestiginous for 30 seconds, and then it settles down, and every time they roll over or turn their head to the left they will get symptoms. And so the treatment is to perform a Epley maneuver to roll the crystals away to the other side, so you're going from the bad side to the good side, and then make sure that they don't sleep on their left side for 4 weeks, because it takes 4 weeks for those crystals to reattach. So if they accidentally roll onto their left side, then they need to redo the maneuver. So you just teach them how to do the maneuver, and there's lots of YouTube videos out there on how to do it, but essentially it's trying to roll the crystals back into the correct spot and then let them set. And if they don't, then it takes about 4 weeks for that to happen.
Great. And yes, Tio is a vestibular physio, so they're often worth their weight in gold.
Yeah, absolutely. And and obviously the patients get huge benefit from seeing a vestibular physio. But yeah, in terms of vitamin D, I'm not sure the answer to that. It wouldn't surprise me if there is a correlation. I wasn't aware of it.
This is a good question from Victor Yan. We've got any tips on managing earwax and and advice on ear syringing in general practice?
So with wax, obviously most patients will tolerate ear syringing really well. The key is not to blast it straight onto the eardrum, but wash it to the lateral canal wall. In terms of in the lead up to syringing, it's probably a good idea to get the patients to use some olive oil in the ears, and I just get them to use cooking oil, go to the chemist and get some, just get a dropper from the chemist and use a couple of drops in each ear at night before they go to bed. In terms of, the only thing you've got to be a bit careful of with that is for patients with dermatitis. So I'll just go back. So if you're looking and there's some dermatitis in the ear, probably not a good idea, because it might exacerbate and cause an Otatus Externa. Or if the patient has a history of ear problems, so if they've got, they could potentially have a perforation underneath the wax, then obviously you don't want to wash water into the ear. So, but if you see picture like this, you really shouldn't be trying to flush it out, because they end up getting excoriation and a really bad infection. So that would be my advice. So, or obviously if you see a picture like this of the Keratosis Obturans, there's no chance you'll get that out with a syringing. But if it's just simple wax, the patient doesn't have a history of any other issues with their ears, it's very safe to use, but yeah, definitely get them to use a week of either Waxhol or olive oil before you do it, and just make sure that when you're doing it, the angle is not straight at the eardrum.
That's great. There's quite a few questions. So Dr. Hopkins has asked, who do you suggest for the voice work for singers? I refer to the voice clinic with Dr. Georgina, I can't think of her last name. It's
Harris. Yep. Yeah, so we do a voice clinic at St George as well with Professor Julia McLean, who's a speech therapist. We see a lot of the oncology patients there that have vocal cord palsies. Yeah, so more than happy to see patients there. If you just send me a referral, I'll book them in through to St George. If not, the St Vincent's Voice Clinic with Georgina.
The preferred intranasal steroid in children. I know that my children's ENT, who's on the other side of town, requests Nasonex because it's cheap and cheerful and no need to go for the fancy newest one on the market. What do you think about that, Justine?
Yeah, look, I think all intranasal steroids are fine. There's so many different brands out there. Nasonex is over the counter and so is, you know, cheaper for the patient. I often put patients on Dymista, and the only reason for that is that if I think they've got allergic rhinitis, it's just easier because the parents don't have to give them an oral antihistamine and the nasal spray. They just give them the nasal spray. But again, the bottle, the Dymista bottle is about $50, whereas the Nasonex is about $20. So it's just a cost thing. But look, any brand is fine. I don't have particular preference for them. And all of them have been shown to have very little systemic absorption. So I don't think in terms of systemic absorption, any one is particularly better than the other.
Now, I think that Dr. Chen wins the question of the day. What do we do with all of these patients with the chronic sinusitis requesting antibiotics for their flare-ups where they often need multiple courses of antibiotics? I've got 2 or 3 of these kind of patients that they just seem to permanently have infective sinusitis. What else can we do with them?
Yeah, so this is sort of a relapsing, recurrent, acute or chronic. So often, look, it's a really tough thing to treat. There's a lot of, and I think that in the future, we're sort of trying to identify what's driving it, if whether or not it's sort of their immune system. So when they get run down, this happens. So trying to sort of manage them from that perspective. There's a lot of research going into gut health as well, and whether putting them on some probiotics or thinking about, you know, fecal transplant and things like that are something that they would entertain, because there is good evidence to say that if the gut is healthy, the nose is much healthier as well. Future directives for this area is going to be things like Xolair and immune modulators. So essentially, I think that there's going to be very little patients having sinus surgery going forward, you know, in the next 5-10 years, because of these new medications that are coming out that are going to be really effective. In terms of antibiotic treatment, look, it's all really, really controversial. If they've got really bad symptoms, they've got fever, they've got complications, then they definitely need to be treated for acute, rhinosinusitis and treated with a short course of antibiotics. If they've got sort of chronic relapsing, often I'll put them on a steroid wash, like a Pulmicort wash, and put them on a 6-week course of doxycycline or a 6-week course of a macrolide and see whether or not that helps. I think that, you know, in terms of the more antibiotics they get, the more unhealthy their gut becomes, and it becomes a vicious cycle. So really, I don't know the answer to this, but essentially I think things will change over the next 5 years. But at the moment, I'd probably try maybe one of the macrolides and see whether or not a 6-week course kind of keeps it at bay for longer, rather than giving them a short course of amoxicillin or augmentin.
Yeah, I hadn't really thought about the gut side of things. The one patient that I reckon has antibiotics all the time actually has really bad IBS, not related to the antibiotics. And, you know, maybe we need to look a bit more at that gut axis stuff in the next 5 years, as you said. There's another question about HPV. I know when I trained at St Vincent's, there was a lot of talk about in head and neck clinic about HPV. And is it possible that there can be transmission of HPV in a household through, say, cutlery and cups?
Possible, yeah. It's possible. I mean, HPV now, with everyone being vaccinated, is going to be again a thing of the past, I think. But yeah, HPV is traditionally saliva transmission. So I suppose, I don't know the answer to that, but I think so. possible.
Yeah, it's good to see the GPs pushing out the tricky questions tonight. I'm just last call for questions, everybody. Then we're going to let Justine go and eat her birthday cake. Oh, sorry, Dr. Mock has one here. Patients with inferior turbinate hypertrophy, how long should we use intranasal steroid sprays for?
So give them a 6-week course and see whether or not they get improvement. So 6 weeks of daily. So I often just recommend in a child 1 spray each nostril at night before they go to bed. In an adult, you can give them 2 sprays, or you can actually give it twice a day. But with kids, I tend to just start them on 1 spray.
All right, I'll ask the final question for the night. Is there any role in prednisone for prednisone tablets in sinusitis or tonsillitis?
So yes, definitely. So there is good evidence to say that patients, particularly with polyps, get significant improvement with oral prednisone. I suppose the issue with that is that they get a lot of side effects. And so there is some evidence to say that the intranasal steroid wash is probably just as good as the oral steroid. And so you're probably better off putting them on a Pulmicort wash than the oral steroid to try and help them reduce those side effects. In terms of acute tonsillitis, if I think it's viral, absolutely, they should be getting steroids rather than, you know, like particularly with the EBV or CMV tonsillitis, because it makes a huge difference. Sometimes if patients are really battling and having difficulty with their oral intake, hydration, and rather than going up to emergency for intravenous antibiotics and steroids, sometimes giving them a short course of a couple of days, like 3-day course of prednisone can help just get them through that sort of period. So I think there is definitely a role for both.